So, good afternoon and welcome to our Northamptonshire Health and Care Partnership session. This is one of two sessions in Race Equality Week. So my name is Anne Linsell and I'm here supported by Diana and Louise, and we're going to support facilitating this session today. Just a reminder that we have for the moment got cameras and microphones switched off. This is to enable a better experience for those watching on catch up. We are recording today's session so that colleagues that haven't been able to attend can watch at a time that's convenient to them. There is the opportunity to ask questions of our keynote speaker today, which is brilliant. And there are a couple of ways of doing this. You can either use the raise your hand functionality within Teams, and at the appropriate point we can turn your camera and your mic on so you can ask the questions directly, or you can put your questions into the chat and colleagues can ask those questions on your behalf. You can also share in the chat your thoughts, reflections and anything else that you'd like to. Additionally, for the colleagues that are hard of hearing, you can turn on live captions within Teams, which will put that on your own screen to support you. So without further ado, I'm going to pass over to my colleague Naomi Eisenstadt to introduce herself and our keynote speaker.
Thank you very much. I was delighted to be asked, and it's very timely in terms of this seminar because I don't know how many of you were listening to the Today program this morning, but the Today program had a very big feature on the disparities in the rate of miscarriage between white women and Black women. And Black women have a 40% higher chance of miscarriage than white women. And what was interesting about the program is that there were acknowledgement that some of this might be biological differences. Some of it is clearly poorer care. Some of it is discriminatory care, but I would argue even in terms of biological differences, it's about, is there investment in research on this in terms of Black women? Is there investment in what you could do to identify earlier what the risks are? You know, you take the same approach in terms of any group and say, you know, are we dealing with this appropriately clinically as well as socially? So I think that it just really, I was really pleased to hear such a big thing on the Today program, but of course deeply disappointed that we still have this kind of disparity in maternity care. My name is Naomi Eisenstadt. I'm the designate chair of the Northamptonshire Integrated Care Board, which basically will be the successor organization to the Northamptonshire Health and Care Partnership. And we have 4 key aims in terms of the Integrated Care Board, which is improving health overall, reducing health inequalities, good use of public money, and to contribute to the social and economic well-being of the communities in which we work. And it was one of the reasons why I wanted to take on the job, because I'm particularly interested in the reducing health inequalities part of this job, particularly for Northamptonshire, where we are a relatively wealthy area, but with very deep pockets of poverty. And great, you know, our problem isn't poverty, it's deep inequality. My background is that I'm relatively new to the NHS. My main career is anti-poverty, family policy, children, especially early years. I was the first director of the Sure Start program. I was also the independent advisor on poverty to Nicola Sturgeon, which was a great privilege. It was really fun, actually. But relevant today, before Sure Start, I was chief executive of an organization that sadly merged with another one called Family Service Units. And FSU in the 80s and 90s really pioneered anti-racist social work practice. We had 40% non-white staff, 40% non-white service users. We worked mainly in inner cities, in poor areas. And we were the first social work charity in the UK to employ Urdu-speaking social workers so that we could do family investigations in mother tongue. And I learned a huge amount about race and racism from FSU, but that's a long time ago. And I have to say, I'm continuing learning because one never finishes learning about anything. So I'm just going to finish before I introduce Yvonne with one of my stories from Sure Start. When I was visiting a small town in Cumbria to meet with service users, which I did a lot as director of Sure Start, it was a big program on under fives that the Blair government set up. And, you know, we were in a rural part of Cumbria, and it's no surprise it was an all-white group of women. And there were lots of children, and it was a very poor area, and it was very ill-served. And I said to the group, I said, well, have you ever been to London? And they said, no. And then one of them said, oh, well, I went to Liverpool once. And I said, really? That's interesting. Did you like it? And she said, not really. Too many colored people.
Mm.
And the whole point of the story was that her permission to say that in an all-white group, and the responsibility it put on me as the posh visitor from London, who's supposed to listen to the community and understand the community and be sympathetic, to respond in a way that would be helpful, but not to let it go, because of course, if you let it go, it's collusion. So I said, so why did that make you feel uncomfortable? And that opened the conversation. And we, who knows? But I think the important point for me was about not colluding by saying nothing, and how easy it is in all white groups for that to happen. And it was, and what I feel very strongly about it, and felt it because my background is so much early years, is that it isn't just about non-white people. It's that the children growing up in that community will have their opportunities limited because they won't be fit to work in Birmingham or London. They will not grow up with an understanding and a wealth of experience and a feeling that normal life is diverse. So it was a very, very important experience for me. And as I say, I'm always learning, and I'm really looking forward to learning from our speaker this afternoon, Yvonne Coghill, who runs a company called Excellence in Action, but has, as we talked before the start, has over 40 years experience of senior roles, both in NHS EI and NHS London as Director of Workforce Equality. Yvonne trained as a nurse. She did mental health nursing, and she did health visiting nursing, and I'm sure she's going to give us a wonderful afternoon. So I'll pass over to you, Yvonne.
Thank you so much, Naomi. I'm absolutely delighted to be here, and even more delighted to meet you, because it's three degrees of separation. And I have to tell you that Nicola Sturgeon is one of the, she's one of the women that I admire totally, absolutely. So it's really, really great to meet somebody that actually knows her. So it's wonderful to be here, and on Race Equality Week as well. So the thing that you were saying this morning, I listened to this as well, the 40 times more likely to miscarry. And we also know that you're 4 times more likely to lose your baby if you go to term as a Black woman. And we know that you have lots of unpleasant experiences, let's call them that, as a Black person living in a white-dominated society. So this afternoon, I'm going to talk a little bit about my story and my journey in the NHS, my 43-year journey in the NHS. I'm also going to talk about why race equality is so important to the NHS, and particularly now that we're moving into the ICS, the era of the ICS. I've been around a long time, as I've said, and I've seen the NHS change on more occasions than you can shake a stick at. But actually, this time, hopefully, we're going to do things a little bit differently, and particularly as we have health inequalities as one of our priorities, and we know that the disparities in our country are widening, and that the groups of people that are experiencing difficulties predominantly are from Black backgrounds. So on that note, I hope I'm going to be able to share my screen. We practiced earlier, but you never know what with these things. It's always quite troublesome, isn't it? With can you all see that? Shake it. I can only see. Oh, fantastic. That's fantastic. So I'm going to talk about my journey in the NHS and how that has impacted on me as a Black woman, and also how I think that race impacts on people within the NHS. So let's kick off. So a little bit about me. I am an African Caribbean woman. I am a very proud Guyanese woman. I was born in Guyana in 1958, and I know people are going to do the maths and work out how very old I am now. But I was born in Guyana in 1958, and before COVID, I would go to the Caribbean every 2 or 3 times a year. I love Jamaica, I love Antigua, I love St. Lucia, I love the Caribbean, and it's where I feel incredibly comfortable. I love people, and I have had a wonderful experience in the NHS, with colleagues, with friends. And so from my perspective, when I look at this and I look at, the times that I've had in the NHS and the times that I've had with my friends and family, I think that I have done reasonably well. So my journey started in Bristol, actually. I was brought up in Bristol until I was 18. Then I left Bristol and came up to London, and I became a staff nurse. I worked at Central Middlesex Hospital in Northwest London. I became a ward sister. I did my health visiting and was a locality manager. And I'm not talking about all of these things that I did to boast or to say, look, here I am and I've done all of these things. But I did these things because I believed that in doing these things and collecting the experience, it would be relatively easy for me to become a director of nursing, because that was my trajectory. I wanted to become a director of nursing. I'm looking at this picture of me 15 years ago, looking very young and vibrant and really, really wanting to become a director of nursing in the NHS. And part of my story, and those of you that know me will know that never happened for me. And I'll tell you why. I tried to become a director of nursing after doing my first degree, doing a second degree, and doing a third degree, actually. So I got my master's degrees and my first degree, all the experience that I just showed you, and I still couldn't get a director of nursing job. I went for 5 director level positions, and as you know, those of you that go for those positions, it's not a walk in the park. You have to really, really work incredibly hard to get even shortlisted for those positions. I'm happy to say that I was shortlisted for all of them. But on the day, I was told that somebody was better than me and they got the jobs. Now, what that did was it made me question my own ability. It made me feel very depressed and low in self-esteem and self-confidence. But also there was a lot of anger and frustration, because if you believe that you can do a job and you can do a job well, but you're not being given the opportunity to do it, there's a lot of frustration and a lot of anger. And the old trope about the angry black woman, well, that was me, because I was angry, and I did. I think I wasn't very pleasant to have around at that time. So I decided to leave the NHS because it wasn't doing me any good, and I certainly wasn't doing the NHS any good. And it was at that time that I met this chap. Now, many of you will know him. His name is Lord Nigel Crisp now. At the time, he was Sir Nigel Crisp, and he was the chief executive of the NHS and the permanent secretary. Now, of course, the role has been split now, and we have a separate permanent secretary and a separate chief executive of the NHS. But at the time, he had both roles. And we had a Labour government at the time, and Tony Blair was the Prime Minister. John Reid was the Secretary of State for Health, and the Minister of State for Health was John Hutton. And what Nigel did at that time, because he recognised that there was an issue, there were at the time 5 chief executives from a Black, Asian and minority ethnic background. Interestingly enough, today we have 8, but that's another story, and we'll talk a little bit more about that later on. And there was a report that came out from the Royal College of Nursing called Getting On Against the Odds. And even with the thousands of Black, Asian and minority ethnic nurses that there were in the NHS at the time, there were only 12 executive directors of nursing. And John Hutton and Nigel decided that they were going to do something about that. And what Nigel asked all of the chief executives in the NHS to do was to mentor somebody from a Black, Asian or minority ethnic background. And I was lucky enough for him to choose me. Now, as I said, I was walking out of the door. I was actually leaving the NHS at the time. I was really frustrated and fed up with it. But there was a chief executive of a strategic health authority at the time called Christine Outram. I think she's now the chair up in the Christie hospital. She actually put my name forward and said, look, I've met this woman. She works in primary care. She's really good. I think you ought to have a conversation with her. And I oohed and ahed about it because I wasn't sure. And my husband said to me, look, you know what? It won't do any harm to go and have a conversation with Nigel. And of course, I went up to the Whitehall to Richmond House at the time. And I told him my story and the usual thing about how awful it was for me and how dreadfully I'd been treated, and, you know, just laid it all on the line. And he said something to me that I will never forget, which was, "Are you any good?" Because I assumed that I was good. I thought I was good. But he asked me the question and I actually stuttered and spluttered because I couldn't articulate how very good I was. And he said, "OK, well, let's put this to the test." And he then gave me the opportunity that I will talk a little bit more about a little bit later on. So here we are in 2022. And in 2022, across the globe, what we know is that if you are from a Black background, and I've got Asian and minority ethnic in here, you actually have a poorer life experience across the board than your white counterparts on the whole. Your health is worse, you have less money, your housing's poorer, you have more contact with the judiciary, and your employment prospects are worse. That is in all white dominated countries, and that goes for people from minority ethnic groups and from indigenous backgrounds as well. So there's something going on in our world that is not fair or right or equitable for people who have additional melanin in their skin. And so you have to ask yourself the question, well, why is that? And where did this come from? And those of you who know your history will know that this has been in the making for the last 400 years, and that it was as a consequence of trying to get economic wealth into countries, into Europe, that what had to happen was that some people had to be recognized as being more worthy than other people, hence the transatlantic slave trade. And that's something that I don't think we've got very much time to talk about here. But this is where this thing about who's better, who is more worthy than who, came from. And it has to be said, and I've heard professors say this is probably one of the most successful initiatives that we have ever had introduced into the world. This thing about race inequality and who is better than who based on the amount of melanin they have in their skin, when we know that melanin in your skin is there specifically to help you depending on which climate you're actually in. So it's really interesting that it's been used to differentiate who's worthy and who is not. Now, the thing I was telling you about our NHS and why this is all very important to the NHS, and I think with ICSs coming on board, I think it's really important that they understand what they are dealing with here, because I believe that race inequality is the single most important issue that the NHS has never dealt with. We have 1.4 million people working in our NHS, and this says 22%, but I happen to know that the latest data will show us that there's nearly 25% of people from Black, Asian and minority ethnic backgrounds working in the NHS. And we know that, you know, lots of our doctors are from those backgrounds because we're continuously going abroad and bringing people into the country to work in our NHS. We have 22% of nurses and midwives, and again, that figure is going up. And in London, on the whole, 50% of the workforce are from those backgrounds. We have 9 chief executives from Black, Asian and minority ethnic backgrounds. And now we have 16 executive directors of nursing, whereas back when I was doing the work with Nigel, we had 12. So we've got 4 more. So how about that then? And I was doing the work with Nigel back in 2004. And we're now pushing 2000. Well, we're nearly at 2024. So that's a good 20 years to achieve what we've achieved. So I'll leave you to think about that. We have 1 ICS chief executive from Black, Asian and minority ethnic background and 8 ICS chairs. So we have 42 ICSs across the whole of the country. And I'll leave you to ponder some of these figures, because I think it's really important that people get an understanding of what is happening in the NHS and why it is as it is. So we have these figures, but why is it important that, you know, there is diversity, racial diversity in our NHS? And those of you who've heard me speak before would have heard me talk about the fact that, you know, it's surely the right thing to do to treat everybody with respect, to give everybody equal opportunities, to support everybody who is working in the NHS so that everybody can reach their full potential. It's also legal. We know that there's an Equality Act which talks about us having a public sector equality duty to actually treat everybody with the 9 protected characteristics, including race, treat them well, not to make their lives difficult or discriminate against them, and so on and so forth. But there's 2 more things that I think are really important in our NHS: the financial case and the quality case. Work by Jeremy Dawson and Michael West has shown that you can actually save the average trust can save over £1 million, £1.7 million a year by increased staff engagement, and also improve the quality of care given to patients, and fewer patients will die based on increased and improved staff engagement in organisations. And we know this through, you know, staff not leaving, not having to pay as much in terms of agency costs and sickness costs and so on and so forth, but also how staff feel about themselves and the organisation that they work in, and being able to give a better service to their patients and their service users. I think it's really important. So when people say to me, well, you know, Yvonne, we've got, you know, it's going to be put on the back burner and we're going to think about other things which are really important in the NHS. To me, I don't know what is more important than this. What is more important than supporting your staff to be the best that they can be, to help the organisation to save money, to make sure that legally we stack up. We're an anchor institution that show that we can do things properly and correctly. And actually, it is the right thing to do. So from where I have been sitting and standing, race inequality is the single most important thing in the NHS that has not been tackled, that has been pushed to one side, that people have decided is not important enough to have a focus on. And I think we're moving into a place where we have to recognise that we've got to do something about this. And what I said to you was about Jeremy Dawson and Michael West is absolutely the truth. And it was back in 2009 when I first saw the document, NHS Quality and Staff Engagement, which I commend to you. And I think you go off and have a quick read. It's an easy read, actually. But what they said was the first time I had seen this written by white professors. And I love them both for it, because when I saw it, I thought to myself, my goodness, the NHS is going to see this and all of a sudden we're going to get some change. That there is a spiral of positivity in the best performing NHS trusts. The extent to which staff are committed to their organisations and to which they recommend their trust as a place to receive treatment and to work is strongly related to patient outcomes and patient satisfaction. That to me at the time was amazing. I'd never seen that before, and I don't think it had ever been written before. And the climates of trust and respect characterise these top performing organisations. Then they went on to say, this is best evidenced by the link between ethnic discrimination against staff and patient satisfaction. The greater the proportion of staff from Black or minority ethnic backgrounds who report experiencing discrimination at work in the previous 12 months, the lower the levels of patient satisfaction. Now, if nothing else should galvanise and move senior leaders, surely to goodness that should. Surely to goodness, knowing that if you treat your Black, Asian and minority ethnic staff well and value them and appreciate them and give them equal opportunities, you're going to get better levels of patient satisfaction. And also the experience of those members of staff. The staff survey shows us what their experience is every year, is a very good barometer for the climate of respect and care for all within NHS trusts. And we know that because there's a couple of NHS trusts where you have high levels of engagement from Black, Asian and minority ethnic staff. And interestingly, those organisations have high levels of engagement from their white staff as well. They have lower attrition rates, less to pay in terms of agency and bank costs, and their patients have a better experience. But I have to add, there are only a couple of organisations in the NHS, and the RES data shows which organisations those are, that can actually say that they have evidence over a 5 to 6 year period that this is the case. So really, really important stuff here that our NHS knows. These things are really important, and they're very, very real. And the question we have to keep asking ourselves is why we don't pay as much attention to these things as we do to other things. Now, in our NHS, I always show this slide because what I call whataboutery always comes into the mix when I'm talking about race equality. And people always say to me, well, what about women, Yvonne? And what about LGBT? And what about, and what about? And I absolutely 100% agree that every single person, regardless of their protected characteristics, deserves to have a really good experience of working in our NHS. But this data shows us something that's quite disturbing. It looks at protected characteristics, and it looks at the people in our NHS, because this is coming from the staff survey, that are actually saying, well, this is not good for me. And the people who say it's not good for them mostly come from Black, Asian and minority ethnic backgrounds. And you can see up to 2019, when the pandemic started, that it was going in the wrong direction for people from Black, Asian and minority ethnic backgrounds. So it says to me that we can't treat all protected characteristics equally, because that's what people talk about. We have to, treat everybody equally. What we're looking for is equity, and we're looking to put energy into groups of people that really need to have that energy, so that we start bringing these bars down, so that we have equity within our NHS. And this is, I think, a quite stark slide, which shows quite clearly that people from Black, Asian and minority ethnic backgrounds are more discriminated against in our NHS today, well, 2019, but the data for 2020 and 2021, I should imagine, is similar, aren't having the most wonderful time. Really important slide. But even more important than that, and which is why I never use, and you haven't heard me use this BAME terminology, is because Black, Asian and minority ethnic people are not one homogenous group. And what this slide shows you very clearly is that there's a hierarchy of preference in our NHS for some people over others. And you'll see at the top of the list here, where we were asking Res Indicator 7, equal opportunities, who thinks they get equal opportunities within our NHS? And you can see that 87.5% of white people, white British people, and 85.1% of Irish people think that they have a reasonable experience, all the way down to Black British and Black other, who have 51.9% saying that they have equal opportunities within their organisation. And then you have all of the other ethnic groups in between in this ski slope that's going down. I think it's absolutely shocking, because this is based on the amount of melanin that people have in their skin. And so people say, well, you can't say that the NHS is institutionally racist. Actually, I can, because the data shows me very clearly that we have preferences in our NHS for certain groups over other groups, and that some groups have a really poor experience of working in our NHS compared to other groups. So there's something that's going on in our system that isn't fair, it isn't right, and it isn't equitable. So from that perspective, I think that we have to all agree that there is an issue. Now, I'm going to quickly whip through this part of the talk, because I think it's really important that people get this, because Naomi mentioned this morning, just now, about this morning on Radio 4, the issue about Black mothers being 40 times more likely to miscarry. Now, this sociologist, Arlene Geronis, a really fantastic sociologist in America, did this work on women in America, every single mother that had given birth in a certain year. And what she found was chronological age, how old you are, doesn't only just capture the length of time you've been alive, it captures the experiences that you've had in that time. And what she found was that Black people were experiencing greater physiological wear and tear of their body and aging more biologically than their white counterparts. She was really surprised by what she had found, but what was happening was because of the stressors in their lives, in their work environments where they lived, this was causing their bodies to age much more quickly than their white counterparts. And this is the biology behind it. In our bodies, we have these things called telomeres, and they are sequences of DNA at the end of our chromosomes. And what she found was that Black women have shorter telomeres than white women. And that's Black women that are, you know, what they call university educated women, women who are judges and lawyers and all the rest of it. Women who are middle class, because the theory is that if you are a middle class Black person, you are not going to experience what working class Black women would experience. Not true. Let's look at Meghan Markle and see her experience of being a Black woman in a society that doesn't always appreciate and value women of colour. But what she found was that at the same chronological age, Black women had accelerated biologically by 7.5 years. So at the age of 50, a Black woman's body would be 57. At the age of 40, it would be 47. Because of the experiences and the wear and tear of discrimination on that person's body. This stuff that I'm talking about here has been in the public domain for a long, long time. We know that this has been tested and retested, and there's evidence, more evidence than you can shake a stick at, that actually racial discrimination causes people to be sick, and it causes ill health, and it diminishes people physiologically. Really important. And the things that cause this are all of these things. And I don't know if you guys heard about the report that came out of the Metropolitan Police last week, when they talked about the banter, that they were talking about, you know, killing Black children and doing awful things to women and all the rest of it, and calling it banter. Banter hurts. I remember when I was young, people used to say sticks and stones don't break your bones, will break your bones, but names will never hurt you. Well, actually, names do hurt you. And so from that perspective, all of these things that people experience, not getting jobs, not having your faith recognized, not having your lived experience believed, or having it poo-pooed, or gaslighting you and saying, oh, you're not really feeling that, that's not really happening. All of these things cause additional stress and strain on people from Black, Asian and minority ethnic backgrounds. And that stress and strain, that constant worry and experience wreaks havoc on people's minds and bodies. You know, the adrenaline is constantly on the go. Even so, that even in sleep, Black, Asian and minority ethnic people's blood pressures was measured to be higher than their white counterparts, because their stress hormones and their adrenaline is constantly on the go, much more than their white counterparts. So is it any wonder that, you know, we have higher levels of heart disease, diabetes, mental health illness, weight gain, poor sleep, all of those things, not to mention the disproportionality in our communities from COVID-19, which you never hear. You never hear it mentioned that all of these things are a potential cause. You hear, well, living in houses of multiple occupancy and living in areas of deprivation and their front-facing jobs and all of the rest of it. But what you don't hear is that over time, the constant wear and tear of living in a society that doesn't fully accept you, and we know it doesn't, because we know from the football debacle last summer, we know from what's going on in cricket, we know from the fact that our Prime Minister talks about pickaninnies with watermelon smiles. We know about, you know, the race and the issues that came out of the police in London the other day, the work that was done by the BMA showing that doctors are discriminated against. There is no argument that people from Black, Asian and minority ethnic backgrounds have a much worse experience than their white counterparts. There's no argument with that. So we just have to go along with that. But over and above the actual event happening, there's this thing called hypervigilance, which is a state of increased alertness. And I know this thing that they're describing here. And what it is you expecting something horrible to happen to you before it even happens. You walk into a pub and you expect people not to look at you. You expect people not to want to serve you. You expect when you go to buy a house that people don't want to sell it to you. Now, that might not be the truth, but because you believe that it will happen, you have this hypervigilance. And in this hypervigilance, your adrenaline is going 10 to the dozen. And it causes the problems, all the problems that are caused by additional stress in your body. So it degrades your body biologically. And as I say, we have the evidence to show all of that. And these are the studies that actually show that discrimination is positively associated with all of these diseases and illnesses. And I am sure that not before very long, we'll have COVID on this list as well, and somebody would have done the work on that. So these are the consequences for people from Black, Asian and minority ethnic backgrounds. And some people will say, well, you know what, Yvonne, things are not like that anymore. Why are people disillusioned? Why are they unhappy and depressed and all the rest of it? They are because they recognise that in the society that we're living in, and all of us have to admit and own that our society has moved more to the right than it was before 2016, it impacts on people and it impacts on their bodies and who they are, and it influences how you feel about working, not only generally, but in our NHS. I don't think I have to go into, you know, what racism is with you, but since the George Floyd incident, which happened a couple of years ago now, people are more likely to talk about racism, and they're likely to talk about and say the word. I mean, prior to that, it was really difficult, and people tended not to say the word very much, racism. But we talk about it now, which is good. That's movement. But what it is a very organised and very sophisticated system. And that's the bit of the jigsaw that people actually don't understand, because they think if we put a little bit of unbiased training in here, or a little bit of reverse mentoring in there, we'll fix this problem. This is a very sophisticated, complex, difficult, deep-rooted issue that categorizes, ranks and devalues and disempowers and differentially allocates opportunities and resources to some groups over others. And, you know, the development of racism is undergirded by this ideology of inferiority. Now, the reason why it is so pervasive and difficult to shift is because people believe that it's true, that if you have white skin, you are more superior than if you have black skin. And therefore, it isn't something that you can change very easily, because it is people's attitudes, their beliefs and their behaviors. It isn't a process, it's a belief system that people have been actually passing down from generation to generation over the 400 years that I've talked about. And this leads to these negative attitudes about difference and about colour. And it leads to prejudice and stereotypes and in-groups and out-groups. And you hear people saying, well, you know what, Yvonne, you know, you have to have somebody who's the right person for the job, haven't you? And that person is invariably a white middle-class male. I've been doing some work recently. I'll just throw this at you. In a trust in London where there are 70% of the workforce from Black, Asian and minority ethnic backgrounds, 70%. In the population, there's 65%. So it's a high population with lots of Black, Asian and minority ethnic backgrounds. In that trust, 5% of the workforce are white men. 45% of those white men are bands 8D to 9, and nearly 50% of those white men are VSM. So, you know, I don't think I need to say any more than that. We can see what's going on here. And that has to change, and we have to do something about it. And we know that, this thing that they call, people say, well, I'm not racist. I've got black friends and I, go and have a curry on a Friday night and all the rest of it. It isn't about that. And it isn't about people calling individual names, though that's not nice. It's about how the system has been developed to actually compartmentalize some people and make some people's lives more difficult than others. It's more difficult for a black person to become a senior leader in the NHS. The evidence shows us that. It's easier for a black person to be disciplined within the NHS. The evidence shows us that. And this is all developed through systems and structures that we've put into place over many, many years. And those systems and structures are very difficult to dismantle because people believe that they are fair and equitable processes, when actually we know from the evidence that they are not. So then the question you have to ask yourself, well, if people know that these processes are not fair, why do they persist? And they persist because they are easier for us to keep things as they are in terms of the status quo than having to do the really hard work of rooting out racial inequality within our systems. So this is something that I developed a little while ago, probably 2 years ago, actually. It used to be the 7 A's of Allyship, but it's actually the 8 A's of Allyship. And I did it because I was asked by senior leaders in the NHS, well, what can we actually do? What is it that we have to do in order to become authentic allies? And what you have to do is do some work on yourself, to be honest with you. And this model actually helps people to think about that. It helps them to, first of all, in the middle, they have to do 2 things. One of them is to appreciate the fact that there is a benefit to diversity and having people of colour working at senior levels in the organisation and being part of everything that's going on. So that appreciation is really, really key. And also appreciating and valuing what people do and how they go about doing it. So that appreciation is absolutely key, as well as appreciating that we have a problem here. This is not right and this is not fair. So we have a problem here. So that's sitting at the centre of all of this. Once you have decided that, yeah, I recognise that there is an issue here, and I appreciate the fact that, these people of colour have something to offer and something to bring, you have to then ask yourself this question: do you have the appetite to immerse yourself in the complex and emotive world of race equality? Because actually, for me, it's better that people stay out of it and not put themselves in it than jump in and out at will, because people do that. They will say, oh, you know what, this is terrible. George Floyd, it's dreadful. I'm an ally and I want to help. And then it becomes too difficult and too tricky. And because you don't have to stay in it, because your skin is not, melanated, you can jump out and say, well, I can't be bothered with that anymore. It's too much energy, too much hassle. I have to focus on something else. If you are going to do this work, you have to stay with it for the long haul. So know that you actually have the appetite to do that, and know that actually when you start to do the work, it becomes more difficult than if you are on the outside just saying, well, I'm an ally. Because being an ally isn't passive, it's an active thing. So really and truly, you have to ask yourself that question. When you have the appetite and you decide you've got it, you have to then start learning about race inequality. And there is so much out there. There's no excuse actually nowadays for people to be ignorant about this agenda. There are so many things to read. There's so many things to see on TV. There's plays, and I mean there's so much stuff on this issue. Educate yourself, understand what's going on around you, understand why people are angry, why people are upset, why people feel that it's not fair and it's not equitable. And once you've done that, you need to then accept internally that this problem is real, and more data on this is not needed, because that's what people used to say. Well, we need data on that. Well, we need data on this. We have so much data. you have to accept internally that there is something wrong, not only with the NHS and society, but our world. There's an issue here. And then the acknowledgement, which is external, is about basically saying, yeah, I acknowledge that there's a problem here. There is something not quite right, and I'm going to do something about it. And that's the bit that's missing. People tend not to acknowledge this openly and loudly. I can't remember the last time I heard somebody. Yes, I do. Chand Nagpal. He actually said something about race inequality recently, and Victor Adabawali did as well on TV. But guess what? Victor and Chand are both from ethnic backgrounds. What we need are for our white counterparts to start talking about this loudly when they have a platform and saying, actually, this is fair and this isn't right, this isn't equitable. The apology is one where you're not actually saying to the individual, oh, I'm sorry, but for you, this is, I'm sorry this has happened in our world, and I'm sorry this is happening to you, and I believe you, and I accept that this is awful and terrible for you. That is really important, that people do that, and not assuming that you know the answer. So, okay, let's put on some training for these black folks, and actually, if they go through a program and become more like us, then we'll appoint them. Or, maybe we'll do some reverse mentoring, and I'll find out more about what it's like to be black, and then I can tick the box and say that I've done my bit. Don't assume. Before you take action, ask and talk to people about what would work and what would be best for them. Then, and only then, do you take action. And I think that, people seem to like this, and they're working with it and turning it into all sorts of modules and doing all sorts of fantastic things with it. And I'm delighted that they're doing that as well, because I think it really is important. The only A that I think I've missed out of here is accountability. And somebody said that to me the other day. You need to add another A, Yvonne. I suppose I can go on adding A's forever. I could add affirmation. I could add authenticity. Well, I've got that one up there. And I can add accountability as well as other A's. But really, really important that we think about what we need to do with regards to all of this. So authentic A's of allyship is one of the things that I did. The other thing that is important is this one, which is developing a race equality strategy. Now, in all the time I've been in the NHS, people have been trying all sorts of different things. This model comes from Harvard University and Dr. David Williams, who I've had the pleasure to work with for the last 8 or 9 years on developing something that actually works. What he would say, though, is that when you develop your strategy, don't expect change, in a year or even 2 years. This is for the long haul, which is why I talk about having the appetite to do it. And it talks about having the vision. What is it that we want for our organization? Having the strong, demonstrative, courageous leaders that will actually take this agenda forward, as well as having the data. The targets. Now, people ask me to have a look at their race equality strategies quite a lot, actually. And usually you'll have 3 or 4 of these headings in the strategies, but you don't have them all. And what David is saying is that you have to have them all. You have to develop all of these within your organization and put equal energy into all of them before you can actually start to move the dial on the agenda. The communications one is so important, because you have to communicate to all of your staff, not just your Black, Asian and minority ethnic staff, all of your staff, why you're doing what you're doing. And it's for the good of your patients, it's for the good of the organisation, it's for the good of the NHS. And that drip, drip, drip feed of communication into the system over time is really helpful. But we know that our communication systems in the NHS are much more conservative, and they struggle and they find it hard to talk about race inequality, and they much rather, on the whole, it would go away. So it's really important that this is something that people think about, as well as the model for allyship. So here are my top 10 tips for success for individuals, and these are the things that I actually think that work really, and they have worked for me. And I think one of them, and I won't go through them all because we're not going to have the time to do this, but knowing who you are and understanding the impact you have on others is really, really important. And this is essential for white people, for black people, for everybody. And knowing how you influence people, and whether or not people take notice of what you say and how you go about saying it. Treating everybody with dignity and respect it goes without saying, but we don't always do it, do we? It doesn't cost to be civil and decent to everybody, but on the whole, you find that people are not, and that's really, really tricky and difficult. But it's something that we all have to aspire to. The having fun bit is the bit that I love the most, because that's who I am and that's what I do, and it keeps you fit and healthy and looking young when you're laughing and enjoying yourself and enjoying your work, and having your family and friends around you. The last one on here is about not holding grudges and being forgiving. And I have to admit that that's a hard one for me, because I kind of remember all the people who were unpleasant to me and made my life difficult and make my life hard and tricky. And I have been known to hold on to the odd grudge or two. But what I know is that if you let it go, it really does help you personally to move on. It's a really, really important and very, very good trick. Looking after your body, yep, absolutely, and doing all the things that you enjoy doing. But also, if you find something that you absolutely love doing, and you're passionate about it, it isn't work. And what I find about people in the NHS is they absolutely love their work. So it makes life easy. But if you love your work in an environment that loves you back, it's, you've hit that sweet spot and it's wonderful and fantastic. So I think it's really important that we remember these things, as well as being humble and remembering that there are people less fortunate than you in the workplace, and that people have had more difficult experiences than you. And I think, being grateful for what you've got and what you've had, and acknowledging that some people have less, it really is important that people do that. And also, finally, sharing your wisdom and experiences. And these are the things that I kind of try to live by and have helped me in my career in the NHS. And finally, my journey's ended now in the NHS, and I'm doing other things. But I have, as a consequence of being supported by Lord Crisp and him giving me the opportunity to work at the Department of Health and meeting lots of different people and gaining the experience and the confidence that I think I now have, as well as getting older, because getting older gives you much more confidence, I think, than when you're a younger person. I've been able to achieve what people would say is quite a lot. And I am very grateful for what I have achieved and all of those people that have helped me. And I will continue for as long as I can to do what I need to do in terms of my journey not only in the NHS, but outside of it, to help people from all sorts of backgrounds to be the best that they could be. So that's the end of my presentation. So I will turn it off, and then we will have our conversations. So let me just put this up here for that.
Absolutely extraordinary, Yvonne. As I said when I started, I'm still learning, and boy, did I learn a lot in the last 40 minutes. But I would like to open it up to questions, please. So are there questions from I say the floor, but from the metaphorical floor? So
Naomi, I have 10 questions here from before. Right. So I'm just wondering if I go through these very quickly, and then we can open it up for the floor, so that I've answered every question. So one of them is, can people of colour be racist? And the answer to that is no, they can't. So racism is a power construct, and I think I showed that in the presentation. But what they can do is discriminate against each other based on different races, different backgrounds. You can discriminate against each other, but the term racism is based on power and who holds the power in order to stop people from getting to where they want to be and how they want to go about doing it and being it. And across the globe, that is people who are from white backgrounds on the whole. So that's why people say that if you are of colour, it tends to be discriminatory as opposed to racist. So I hope that answers that one. Then it talks about, as a white person, how do I speak to my white associates and friends about their racist beliefs? That's a nice question, isn't it? So it's the thing that you said earlier, Naomi, about calling it out and saying it in a way that people are going to hear and open it, allowing them to open up and talk about why it is they think what they think, but actually calling it out and saying, well, actually, you know, let's think about this. And I always say to people, use the data. It's, you know, the data isn't personal. So if you use the data, you can say, well, let's think about this. In our NHS, we have, you know, 1.4 million people, and, you know, 25% of them are from Black, Asian and minority ethnic backgrounds. Yet we only have 8 chief executives from those backgrounds and 16 members of nurses. So why do we think that is? You know, what do we think is going on there? And amongst white colleagues, have that kind of conversation, because I think that unless we have those conversations, we're not going to get anywhere. Use the data. It's always because it becomes less personal, and it really is helpful to be able to talk about these things. Then it says, how do we engage with white leaders who do not believe that racism exists? Again, I think that you'd have to be a really, really tough nut if you didn't look at the data and think to yourself, well, there's something not right here. So again, I think that there's something about engaging with white leaders about the things that really matter to them. And what matters to senior leaders are things that I've mentioned. It's high quality patient care, patient safety, satisfaction, saving money, saving lives, and how those link with race equality. And if you can talk to senior leaders about how it is that having a workforce that's valued, appreciated, a workforce that really feels that they are part of something, helps you to get to your the objectives that your organisation are aiming to get to. Better patient care, better patient safety, you know, all of that kind of thing, not having to constantly recruit people because they're going off sick or leaving. I think that will work. So I'd go along with that. So that's one. The 5th question is, does unconscious bias training work? I love that question. I always get asked that question. Wouldn't it be brilliant if it did, though? Because if it did work, we wouldn't actually be here talking about Race Equality Week, because we'd have solved the problem. And what race unconscious bias training does is it raises people's awareness of the fact that there are biases that we all have, you know, whether you're black, you're white, or whatever. We all have biases. We all prefer some people more than others. We all prefer some things better than others. But knowing that doesn't necessarily stop us from actually having really quite fixed thoughts and views about other. So raising awareness is a good thing, but it doesn't necessarily stop, you know, the inbuilt racism and systemic and institutional systems that we have in place that need to be dismantled. So that's that one. Then it talks about the thing that I never mentioned, which is BAME and BME, because if you notice throughout my talk, I said Black, Asian and minority ethnic, and not these awful acronyms. It says, please explain what the terms BAME and BME mean and why people find such labels unacceptable. Well, the reason why people find them unacceptable is because it lumps everybody together in one homogenized group when we know that everybody is different. We know that one Asian person is different from another. If you come from Pakistan or Bengal or Bangladesh, you have a different experience to if you come from the Gujarat or Punjab. And so we need to start separating out and being more granular in our approach. And I showed that in one of my slides in terms of different groups of people of colour being treated differently or experiencing the NHS differently within the NHS. The Race and Health Observatory, and I'm a board member at the Race and Health Observatory, has done a really wonderful report on terminology, and it talks about why it is we shouldn't use the terms BAME and BME. It's just so yesterday. We just need to let that go. Then another question is, would you recommend staff who are fearful of being targeted to share their lived experiences of racism discrimination in an open group that's chaired by white leaders? Well, this is an interesting one. I am actually on the board of the Institute of Health Improvement in Boston, in Massachusetts. And when I first started on the board, I had a really great experience, because what happened was not only were people of colour asked to share their experiences of life, but the white colleagues were asked to share their experiences of life as well. And what we usually do is listen to the poor old Black, Asian and minority ethnic person tell their story, but we don't listen to white people's stories. And I have to tell you, white people's stories are fascinating, absolutely fascinating, how they've got to be where they've got to be, and how you can understand why it is that they are where they are. So what I would say is that you both need to tell your stories. It's not a one-way street where people are just soaking up all the information about these poor Black folks. Try to get everybody to talk about this story. I think it's a really, really good idea to do that. How do you get an organisation to understand that institutional racism has empowered the structural racism in the organisation, which has supported racist behaviours? Some white colleagues are not fully conscious of such behaviours. When challenged, can be quite defensive. Again, I think it's, this is, as I say, using the data is always quite helpful. But if you come from a white background, and this is something I didn't get for a long, long, long time, if you come from a white background and you don't know very many Black and ethnic minority people, and you haven't mixed with them, and you believe that actually we live in a fair and equitable society, it is hard to hear, isn't it, that some people are having a harder experience than you have had, and that things are not the same for them as they are for you. And you have to come to a place where you recognise that that's the truth. And you can only recognise that if you have, and we love this in the NHS, the research, the evidence that actually shows that they have different experiences. So it's how you actually engage with people and talk to them about all of that. The RES data is great for doing that. It's really fantastic, because over 7 years, we've got this data. And what we also know is that things are not changing very quickly in our NHS as a consequence of that data. So hopefully it'll be something that people in the ICSs will take on board and think about quite carefully. The next question is, there's a lot of talk about white privilege and white fragility. What is that about? Well, I think that, we've talked a lot about this session, and white privilege is not about the fact that, some people have, had poor relations, and their mother was working class and their father worked on the buses and all the rest of it. This is about the benefits you get just from being white in society. It's not that, if you have a poor Black child and a poor white child, the poor Black child has to contend with racism as well as everything else that goes with being poor. Whereas the poor white child doesn't have to deal with being Black and all that goes with that. So privilege, and I don't call it that, I call it unearned social capital, because it kind of it's easier for people to digest. They kind of don't like this privilege word because they don't see themselves as being privileged. But if you talk about social capital and the fact that your social capital is higher than somebody else's just based on the color of your skin, people tend to think about it. And the white fragility part is an interesting one, because that's about the defensiveness and people not believing or wanting to talk about race and putting up barriers. There is lots of data on things like white women's tears and people not wanting to talk about this because actually it upsets white people. We can't say anything because it's going to make their lives very difficult and hard, and they're going to be resentful and so on and so forth. So what Black people then do is not talk about it, or they try to protect the white person from hearing this stuff, causing themselves more stress and strain. It's a real thing, really, and more work needs to be done on that. And my final one is, how do you overcome challenges from senior leaders to get their buy-in to support and progress race equality initiatives? Do you know what? I think my personal view on this is that white leaders who don't buy into this need to be shown the door, because actually we employ our senior leaders to look after all of the people all of the time, and they get paid a substantial amount of money for doing so. So when senior leaders don't want to engage with this agenda, I think other senior leaders need to actually recognize that and have a conversation about whether or not this is the right job for them in the right organization, because you actually have to engage with this to actually do your job properly. And I believe that 100%. So that's all my questions, Naomi. I think I've answered them all.
Absolutely brilliant. Are there questions from the floor? There were some in the chat, but I think they've sort of been picked up by what Yvonne said. So I've got Diana. Do you want to come in with a question?
Hello.
Hi, Yvonne. How marvellous it is to see you again and to hear your inspirational presentation.
Bless you.
Thanks so much for doing this. Yvonne, can we ask you that in your experience, you've been at this for a long time. Is this ever going to end?
Oh God. Diana, why did you ask me that question? You know, I know that it's not going to end in my lifetime. Okay, so I'm 64 years old this year, and I don't think so. I don't think I'm going to be alive to see it end. But I tell you what, though, I think that probably in another couple of generations, we're going to see lots and lots of change. We have to. You know, this country is changing inextricably. It's not, you know, people might like to think we're still back in 1948 when the NHS came into being. But actually, it's changing in terms of its demography. It's changing in terms of its culture. It's changing in terms of, you know, how the world sees it, actually. And I think it's going to have to change in order to be a successful country again. And to get to where it wants to be again. And if it doesn't, well, I don't know. So I think that it will change. I think things will get better. I mean, people are talking now that we're going to potentially have our first Indian prime minister. I wait to see that, to see if that happens. But people are talking about it already, and they wouldn't have talked about that a while ago. That would not have been something that it was in anybody's thoughts or their mind. So I think that things are going to change, but I don't think they're going to change quickly, and I think we have to get to grips with that. Good question. Good question.
Thank you. Anne, do you want to come in with a question?
I will. Yes,
Collie.
I'm just looking through the chat, and Yvonne, please know that there is such a huge amount of love in the chat and support, and you know, just the conversation has been so powerful. So a question that we had in the chat from Patsy. Yeah. What's the best way to deal with people who are so afraid of being labelled racist and turn it around to make the person calling out their use of the stereotype the bad person and themselves the victim?
That's a complicated question.
Let me see
if I got this right. This is about if the person who is the black and ethnic minority person is trying to read it to me again.
But unless Patsy wants to come on and ask the question directly, Patsy, do you want
Patsy,
to
come and ask me.
Patsy.
Is Patsy there? She's probably shy.
Okay. Yeah, she's there. She's just coming on.
Oh, great stuff.
We're just unmute. There are, Patsy. You should be able to come on board now.
Great stuff.
You there, Patsy?
Hi, Patsy. I can't hear you.
I've unmuted myself now. Hello, Yvonne. Lovely to see you again.
And you. Nice to see you.
Yeah. This is more of a personal thing.
Yeah.
But it would relate to like colleagues and so on. But you know, you need to call out things that people do because they're not aware of it. But it's how do you deal with it when you do that and the person just gets so defensive that you're the bad person. You know, they're so afraid of being labelled as racist, which, you know, you're not doing. You're just trying to highlight something that maybe they're not aware of.
Yeah.
How do you do?
It's a tricky one, but you know what? I think, Patsy, because I'm just looking at you now, and you look as if you care, and you want to get it right. So it is about actually trying to explain to the person about racism, but not in a personal way. So I keep harping on about using the data, don't I? But actually, it's a really good way of having a conversation with somebody who is being defensive, because what they're trying to do is protect themselves and say, I am not racist. It's not me. And what you're trying to say is that it's not about you. It's about the system. It's about how the system has been developed to give us perfectly what we have got. And what I need from you is for you to help me to try to unpick that so that we can actually, all of us, have a better experience of working in our organisation. And so using the data is for me the way to go about doing that, and saying, look, you know what, this isn't about, I'm not honestly not talking about you personally. What I'm talking about is how we together, because we as Black folks, we can't do it without white people, we have to do it together, how we can actually make our NHS a better place for all of our patients and all of our staff. I think it's how we go about talking about these things to people, because we can get defensive as well and say, oh, for God's sake, you know, how many times do we have to tell you, you know, we can become defensive. But actually, you know, if we try and get people to a place, and I say this to my Black, Asian and minority ethnic colleagues, you know, we have to understand that white people are coming from a different place to us. They're not, they've had different experiences, different life experiences. And so they're not always understanding of where we are coming from. So we have to try to get them to where we need them to be. And that takes time and energy. Takes energy, Patsy.
Definitely.
Keep going, girlfriend.
Yeah, I will. Thank you, Yvonne.
You're welcome.
So can we pick up a question from Mohammed Kohli, please?
Hi, Yvonne. Thank you very much for. Can everyone hear me? Yeah.
Yes, I can.
Yeah. Hi, Yvonne. Thank you very much for the talk. It's been wonderful. So I just want to go back to something you said about how, when Diana mentioned about will this ever change, and you said in this country where there's a possibility of Rishi Sunak being talked up as potential prime minister, but is visibility enough? Because you see the abuse that Sadiq Khan receives as the mayor of London. I mean, and if you even go back further to Barack Obama when he was president of the US, where people were questioning his birth and whether he had the eligibility to be the president, etc. So my question, and we've got cabinet members, which the Conservative Party have openly said that we've got the most diverse cabinet ever, but then we've got people who are actively legislating against BAME people legislating against BAME people. So therefore my question then goes, is representation enough, or do we need to do a lot more?
You've answered your own question, haven't you?
Yeah.
And people have said to me, you know, if we didn't have Obama, we'd never have had Trump, because what happens is that when people from Black, Asian and minority ethnic backgrounds get into senior level positions, it tilts the world order a bit. It shifts it. And you get people who are very, very, very right of centre really coming out very strongly about, you know, why it's not such a good idea to have these people in these positions. The other thing that happens, and you're absolutely 100% right about this, is that the people that sit at very senior levels from Black, Asian and minority ethnic backgrounds, and this is across the board, tend to be much more English than they are African or Indian or, you know, West Indian. They what I call assimilate, and they assimilate to be able to function in those societies. So work has been done on this assimilation in America. I don't think we've done it here. We haven't done it here. I haven't read anything about it here. But this is about people making a decision about getting on in the workspace and what they have to lose in order to get to where they want to be. And so I think we're in a society where no, representation isn't enough, but acceptance and people understanding that we have something more to bring, more to offer is where we want it to be. But saying that, isn't it better to have a few people of colour sitting in senior level positions than none? So we're in this awful sort of Twilight Zone-y type place, aren't we? Where there's, you know, people representing different colours and cultures and all the rest of it. But actually they're not what I would call authentic, because of what they are is they've assimilated and they become much more English. I mean, if I was listening to that Kwasi Kwarteng speak on the politics show on Sunday, and when you close your eyes, he sounds more like, you know, Jacob Rees-Mogg than Jacob Rees-Mogg does. I mean, he really does sound very, very English. And that, I think, is something to do with the acceptability of people of colour that look like and sound like English people. I think you're absolutely right, and it's a point well made. Thank you, Coley. Thank you.
Right, as usually happens, we now have a queue of questions.
Oh.
So if you can take a couple at a time so that we can get through them, because I think letting people have their say is really important. So if we take Derry and then Carol, and then we'll go back to you, and then after that, Angela. Okay, so Derry first and then Carol.
Yeah.
Derry? Derry, are you there? He is putting it in the chat. Do you want to ask your question out loud? Well, okay, why don't we go to Carol and then I'll pick it up from the chat, okay? Carol Werner.
Hi, Yvonne. Good afternoon, everyone. Yvonne, I've got a question for you. Okay. A lot of training is coming up for BAME staff in different staff groups. And my perception, my reflection is I already have the understanding that a lot of people from minority ethnic groups, they come from enforced academic backgrounds. So they're very knowledgeable. What we lack to go into leadership roles are efficacy, confidence, because our cultures were very disciplined and very strict. And I'm not seeing any training coming to offer that. So when people go into those training or into those interviews, they are told you're not management material. It's not that the manager is not, the manager is hidden within them, but their upbringing told them that when you're angry, don't speak. So it offers you don't. So when I'm quiet, my manager knows that I'm angry. It's just I'm recomposing myself, but it's taken him a long time to understand that.
Yeah.
So my question to you is, do you amplify all these trainings and agree with them? Because I'm just seeing it as a tick box, as an individual, as a person, Carol Vanna. I'm seeing it as a tick exercise because I'm not seeing that's the need to help address those disparity ratios for BAME staff, because that's not what we need. We just need someone to hold us into, develop us, walk us, give us the opportunity to say, okay, you're band 8B, I'll walk you through this role, give you the experience, and then let us fly.
I agree. I couldn't agree with you more. I mean, when I did the work with Nigel back in the day, we didn't have the evidence that we have now. So at that time, what we did was we talked about, let's train these Black, Asian and minority ethnic people, make them better. They'll be more like us, and then they'll get the jobs. That was what was. What we've learned since then is that it's not about these Black, Asian and minority ethnic people. It's about our systems. It's about our processes. It's about how we in the NHS have developed perfectly the systems to give us what we've got, which is more white people sitting at the top of organizations. And Black, Asian and minority ethnic people need to have access to more senior leaders. The program that I ran called Breaking Through many years ago, I'm really proud of that program because 68% of those people who went on that program are now the directors in the NHS. And that was because we linked them with a senior leader who actually was not just a mentor, they were a sponsor for them. They encouraged them. They got them to understand the minutiae of the NHS, because the NHS is like an iceberg, isn't it? It's got a little bit on top with all the processes underneath, but the culture underneath is like huge. So you have to understand and know how you navigate yourself through that system in order to sit on the board and to be somebody that's not only accepted at board level, but really can contribute quite a lot. So learning that is what we need. It's not getting more. I've met Bantus with PhDs and coming from Africa and all the. We need our white counterparts to open the doors and to help us and to hold us by the hand and let us in to these senior level positions. Angela, it's fantastic to see your beautiful face. Nice to see you.
Okay, can we pick up the question from Derry and then Angela, please? So I can see that Derry's there now.
Hi, hope you can hear me.
I can.
Yep.
Yeah. What a lovely absolutely fantastic talk. The only problem is, Yvonne, I think you're preaching to the converted.
Yes, probably.
The very fact that we've signed on means, I guess, that we already share your vision.
Yeah.
And that's a challenge in itself, isn't it? But what I would say is, in other fields where I work, we have community champions.
Yeah.
Should we have community champions, designated community champions for your work, to spread the word, so that we will understand more because we'll have more training, and we can influence because we're in different places. And it just makes sense to me, because I think that, you know, nobody would expect that a white woman would be championing Black causes, Asian causes, whatever. So should we be out there a bit more and say, do you know what, we're doing this? Yes, we are.
I love everything that you've said, Derek, and you're absolutely right. When you say it, it's much more powerful than when I say it, because Yvonne Coghill would say that, wouldn't she? But actually, if Derry Miller says it, oh, she's a white woman, you know, white middle class woman, she's saying it, we might sit up and take notice. So I think you're absolutely right. And in lots of places there are, they call them ambassadors, or, you know, people who actually help. We've got res experts in the mix as well, who are supposed to be out there helping and supporting and doing what they need to do to raise the profile of this. But, Derry, the important thing is the chief execs and senior leaders. They are the ones we really need to start moving this agenda. Instead of passing it down the line to the band 8 or 7,
to pass up.
It needs to be them who are speaking about this and actually championing it. And I can see your chief exec on the call.
Yeah, and getting, you know, getting slots on agendas. That's important.
And really talking about it. Demonstrable leadership is what we need on this. And too often people don't, because they don't think about it. They don't think that it's important, and so they sort of shove it over there somewhere and let somebody else.
I mean, when I look at it, I look at it from the perspective of a personal point of view. Was when my father was very ill and when my husband was very ill, who was looking after him? All across the board, including fantastic Chinese doctors, Asian doctors, Black doctors, whatever. Absolutely fantastic. So I just think that, you know, we're missing a trick.
I agree.
Some of us don't band together and just say, do you know what, we're going to be a force to be reckoned with where BME is concerned.
You're a champion, Derry. More power to your elbow. Keep going, keep doing, keep saying these things.
Let's do it. Somebody needs to collect it together.
Brilliant.
Right, Angela.
Right. Hi, good to see you, Yvonne. As ever, inspiring. You know how I feel about you, you really do. But thank you very much. But absolutely agree with you, Yvonne. I think there is a real opportunity with ICSs now that could be seized. My worry is, though, that they will become, again, left to their own devices, and the variability will be significant. Again, it'll be down to happening in some patches, not in others, some leaders taking it forward, others not, and that element of choice is going to be a problem. Is there anything going on nationally to make this a key priority for ICSs? Because we know that is where people then focus their attention with the competing priorities. As Derry said, there's people like ourselves here, there's others not. How can we make it an ICS priority, not just locally, but also in that national context?
I think you're absolutely right. And I think at the very beginning of this, Naomi did say that there are 4 key priorities for ICSs, and one of them was around health inequalities, which this kind of like sits very much within that. And I suppose it's how people interpret health inequalities, because you can actually work on health inequalities without actually touching race at all. You know, you can actually look at the wider determinants of health and all that kind of thing, and not touch this one at all. I think that the NHS has got to this. It's too. It's like a red flag, isn't it? You know, the race equality for senior leaders in the NHS to ignore it now. And if they ignore it, Angela, and they go on and do other things and they don't do anything about this, it means that it's willful. It can't be ignorance, it's willful. And if that's the case, then the conversation has to be, well, why are you willfully, deliberately not paying attention to this? And it'd be interesting to hear what the answer would be on that. I think it's good. I think the centre has begun, and this is my personal view, is going to become less and less important. And the ICS is going to be much more the place where things are going to be, we're going to be able to make the change that needs to happen for our populations and our workforce. And so I'd be looking to, and that's why I'm so delighted to meet Naomi today, because she's one of the first ICS chairs that I've met outside of London. You know, seriously, and I understand our Krishni is now an ICS chair as well. So that's fantastic. That's brilliant. Oh, Krishni.
Yeah.
Brilliant.
And the truth is, it is much harder outside of London. It's much harder.
Yes, it is. I'll be coming to, where are you? Herefordshire or somewhere like that?
No, I'm Northamptonshire and Krishni is Herefordshire, but yeah, I'm getting a lot of my advice from Krishni. We have only a few more minutes. So, and we have a final slide. So, Yvonne, absolutely brilliant. And I do want to stay in touch because there are lots more things. I want to take up with you some of the things about the differences in racism in America and Britain as an American. So that's another conversation because I think it really is different. But I'm going to, if you do you have any final words you want to say, and then I'll ask for the last slide.
No, well, it's just to say thank you so much for having me during this Race Equality Week. It's been brilliant. I have had some wonderful questions, lots of great engagement, met lovely people that I've met before and hopefully become friends in future. And I wish you all the very, very, very best, all of you, in your endeavours for our NHS to be the place that it deserves to be, which is fair and equitable for all. So thank you so much.
So brilliant. Thank you very much. And can I have the last slide, please? So this is our NHCP commitment in terms of our 4 steps, which is developing and implementing an equality, diversity, and inclusion strategy. I'm kind of disappointed that we don't have one already and that we're not on implementing, but we have to get going on it. We certainly have to do it for the ICS. I think supporting the progression and development of Black, Asian, and minority ethnic, I agree entirely with Yvonne about the expression BAME, which I've never liked. But part of that I've seen in work that we did in Trust for London on, believe it or not, the construction industry and African Caribbean men, you know, where it's always the Black men with the shovels and always the white men watching them shovel. So we did a really specific piece of work on that I learned a lot from. We are launching an NHCP Allyship network so that we can help each other in these issues and in the different intersectionalities, and reverse mentoring in terms of helping us white folk to learn, which I think is always a very, very difficult part of it, and enabling us to ask the right questions and to say, did I get it wrong? Was it okay? I think all that's very important and very scary. But as Krishni and Angela went up, as they work with me, I always like to end these sessions with a story. And Yvonne gave me permission to do it with fun and to have a joke. So this is a true story, and I'm afraid it's intersectionality, only partially race. So about 25 years ago, probably 30 years ago now, my sister's first husband came out as gay. So obviously the marriage was going to break up, and she had 2 young children. And all the adults were sort of in corners talking about, oh, what effect will it have on the children and what should we do and all that. But I'm a children's rights person. So I went to my 10-year-old niece and I didn't say, how do you feel about your dad being a homosexual? I said, how do you like Ken, who was her father's first boyfriend? And she looked at me very seriously and said, Ken's very nice, but he's not Jewish.
Oof.
So it's about what's important to whom.
Absolutely.
Needless to say, Ken is long gone, but Lisa is still very close to her dad. So I'll finish with that. And thank all the people who attended. I do worry about preaching to the converted, but for all of us, it gave us loads of ideas to keep doing the work. So thanks very much, Yvonne, and thank you all for coming.
Thank you.
Bye-bye.
Thank you, and thank you, everybody. And we will share the link to the recording with everybody that's been on the call today. So yeah, thank you, Yvonne. It's been brilliant. Thank you, Naomi, and thank you for everyone that's joined.
Take care.
Bye-bye.
Bye, everybody. Bye-bye.
Bye.
Bye.